letting them have a patient-centered experience, and then also leveraging on behavior change communication as one of the things that we do. So this project started in January 2024, and is primarily in the Greater Accra region, Ashanti region, and then Northern region. So what we do is that we have two approaches. So we have the hospital-based approach and then the community-based approach, where the hospital-based approach, we interact with patients with breast cancer, and we try to explore what their feelings and fears are regarding their condition, try to find out their ideas, and then how is the condition has impacted their function, and then also what they expect from healthcare providers, all geared towards being able to make their experience, better. And then also the caregivers of these patients are also not left out. And then in the communities, we also do community activations where we interact with community members, opinion leaders, and then just to educate people on breast cancer, looking at things like self-breast examination, signs and symptoms of breast cancer, and also giving them opportunity to ask questions. But then one of the key aims of this project is also to empower healthcare providers to be able to provide, holistic care to patients with breast cancer. And that is the reason why we organize this continuous professional development programs, just to help, refresh our memory and also to build capacity of healthcare providers so that whenever we come into contact with patients who have breast cancer, we are able to give them the right information and then also encourage people to adopt some of the early detection techniques. So without taking much time, I want to hand over to our moderator, who is an experienced consultant family physician, and I am sure he will be able to steer the affairs very well. So, Dr. Norte, please, over to you. Thank you very much.
Thank you very much, Dr. Amu, and I must say that I'm most privileged and honored to be part of this all-important series that you have initiated. As you are aware, breast cancer continues to plague, the world, and especially, create all sorts of challenges for countries like ours. Is the most common cancer in women in Ghana. And I would say that, in my professional career as a young doctor, I remember the emotional, attachment that created a lot of problems for me because, you were seeing patients that not much was being done for. You had seen them over the years, you had gotten attached to them. And sometimes the end game was quite difficult, as to the point of even impacting the human dignity negatively. This afternoon, we are not going to talk about breast cancer in general, but we'll look at aspects of this management because a lot has happened over the years, and there is now emphasis on multidisciplinary approach to the care. For this afternoon, we are going to look at it from the perspective of palliative care and then breast cancer in pregnancy. Our first speaker is a specialist family physician and a palliative care fellow in training. She's currently, the head of the palliative care unit at the Family Medicine Department of the Kolebu Teaching Hospital. She has done quite a lot over the years, and she continues to contribute in diverse ways. She's also, contributing to academic medicine as part-time lecturer in both Family Health Medical School and Accra College of Medicine. She holds an MB, CHB, and BSc in Human Biology from Kwame Nkrumah University of Science and Technology. And is also a member of both the West African and Ghana Colleges of Physicians. In addition to her clinical and academic duties, she has pursued further training in leadership, health administration, and spiritual aspects of care, making her a well-rounded advocate and educator in holistic patient care. Please let's welcome Dr. Abna Sapo. And she will be our first speaker, and the topic is palliative care in breast cancer. She will have 30 minutes to do that. And then after that, our second speaker would also do the presentation. And then we'll have some time for questions and contributions. So please note down your questions or contributions in the chat box. So Abna, please, you can share your slide. You're welcome.
Thank you very much, Dr. Naughty. It's always a privilege to have a very senior colleague introduce you like this. I think Dr. Naughty played a role in pulling me to family medicine, and I'll always be grateful. So, as was said, my name is Abna Sapon, and today I will be speaking on palliative care in breast cancer. We're going to start with the case vignette, and this is actually based on a true life story, somebody we saw a few weeks ago in our clinic. So Madam TK is a 48-year-old woman who is also the founding pastor of one of the charismatic churches in her locality. Madam TK is married with 2 children. Her first, called Amma, who's 24 years and recently visited her in Ghana for her wedding. Her second, who was her miracle baby, who actually came years after Amma, is Issy, her 6-year-old daughter. Life seemed almost perfect in every sense for Madam TK. However, 2 years ago, she noticed a lump in her breast when she was trying her hands on a self-breast exam she had, seen on the television. She reported to the clinic after she felt that lump. A mammogram confirmed the lump, and then a biopsy was done. Right. So, Madam TK, according to her, from the time the biopsy was taken till the time she got her result, she said to have parted ways with a good night's sleep. She could not concentrate on anything, and this was actually beginning to affect her husband as well. So on one fateful day, they reported to the clinic and were super early. They got there about 2 hours before their scheduled appointment time. And her heart skipped a beat as her doctor pulled up her results and started looking at it. The doctor, after seeing the results, said, "Oh, Mrs. TK, you have breast cancer, and we'll have to cut off your breast, or else it will spread, and you will have less than 5 years to live." Mrs. TK, who was scared and confused, made this known to the doctor. But the doctor responded and said, "Well, I'm only trying to help you. I can't force you if you don't want to. But if I were you, I would listen. The clinic is very busy today, so let me know when you make up your mind. Next patient, please." And then the doctor went on. This was the start of Mrs. TK's breast cancer journey. And she vowed that having a doctor's review would never be part of it. She felt the communication had been so bad, with very little time for her to think about it, absorb the news, and also that if she was going to die so soon and nothing could be done if her greatest fear was not addressed, then she might as well find alternative means. So she decided to try herbal medication. and also pray that the God she knew would heal her. So this is Mrs. TK's story. Hopefully we'll meet her again as we move on with this presentation. I'll start off with an introduction to breast cancer, and this is using the Global Cancer Statistics 2022, GlobalCan 2022. Breast cancer is the second most common cancer among both men and women globally. And in women, it's the most diagnosed cancer. In 2022, according to the statistics, it accounted for about 2.3 million new cases of cancer. And it also carries a significant burden in middle and lower income countries like Ghana. Breast cancer accounted for about 31.4% of cancer incidences in Ghana in 2022. And with this number, about 70% of women are diagnosed at the advanced stage. Breast cancer at different stages of the disease presents with its own unique spiritual, psychosocial, and physical needs. And all these needs have to be met. And that's where palliative care comes in. Palliative care is crucial in improving the quality of life of the patients and their families, irrespective of the prognosis. And so palliative care can be started and should be started at any point in time because it's based on the needs, and the needs arise at any point in time. I know most of us may know about palliative care again, but I'd like to just go over again what palliative care is. In terms of definition of palliative care, it's undergone a lot of changes, but I'm hoping that we have changed as the definition has changed, because that would have a great influence on our referral patterns and the way we see palliative care in total. So in 2002, the World Health Organization came up with this definition of palliative care. And it said that it's an approach. So it didn't say a subspecialty. Approach means a way of doing things. So it's an approach that improves the quality of life of patients and their families. For most family physicians, this is very common to us. Patients and their families facing problems associated with life-threatening illnesses. Now, life-threatening illnesses are illnesses that may or may not be cured. They could or could not kill you. And so palliative care improves the quality of life of these illnesses. And it does that through prevention and relief of suffering by identifying problems early and then assessing the people holistically, and also treating pain and other problems that may come with it, which could be psychological, spiritual, or social. This is really a mouthful, and so sometimes it's hard to remember, but simply, palliative care is providing comfort care for a patient and their family and making sure that that care is holistically done. Now, this was in 2002, but in 2018, the International Association for Hospice and Palliative Care had a conference, and it was made up of both Anglophone and Francophone countries, and together they came up with what they call the consensus-based definition. Wasn't too different, but this said that palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially those near the end of life. It didn't restrict it to only those at end of life, but it said that anybody that had a serious health-related suffering had to be provided a care that was ongoing to them. And the aim was to improve the quality of life of the patients, their families, and their caregivers. And so in this definition, even the formal caregivers, people who take care of them in hospitals and others, became part. A lot of people tend to think that palliative care is just end-of-life care or hospice care. And so I brought this up so that if we are still in that mentality, we would swiftly move away from it and be abreast with the current definition of what it is. So palliative care is the big umbrella. Hospice care, on the other hand, is more towards end-of-life care, or it's care provided to people with a prognosis of 6 months or less to live. It focuses on providing comforts. It doesn't seem to want to hasten or prevent death, but just provide comfort as the natural process goes on. In some countries, you would need about 2 physicians to certify that a patient has less than 6 months to live. In Canada, it's about 3 months, and in the US, is 6 months prognosis. And so for hospice care, curative care is not really the mainstay here. It's just about providing comfort care in situations where cure is no longer an option. Okay. So what are the key principles of palliative care? Its aim is to provide relief from pain, and pain is not the only symptom you are relieved from. Any distressing symptom. We'll talk more about that. Palliative care actually affirms life and regards dying as a normal process. And so palliative care in our settings, especially in Ghana here, does not promote euthanasia. Actually, if a patient should ask for euthanasia, it means that the palliative care is questionable. The patient is suffering so much that they would want to end their life. It integrates spiritual and psychological aspects to the patient's care because this is part of life and this is part of health. Palliative care offers support systems for patients to live as actively as possible and for the families during the illness and bereavement. So in palliative care, even when the patient dies, care does not stop. Because the family is involved, bereavement care is also offered to them. And palliative care is not for a single person. It uses a team approach to address the needs of patients and their families. It enhances quality of life and will actually positively influence the course of illness. Most people would not refer patients because they feel that it would have a negative impact on them if they do so, but this is not so, and we'll see that as I move along. It can be applied early in the course of the illness. It should not come in only when curative measures are no longer an option. Palliative care should be applied early in the course of illness and can be done in conjunction with other disease-modifying regimens. So it doesn't mean when there's nothing that we can do, refer to palliative care. You can refer a patient to palliative care even when you're continuing to care for the patient. So the stages of breast cancer can be wide, it can be long, it can be very unpredictable. And at each stage, I wonder if there's any stage at all where there might not be any need. We start with pre-diagnosis, when somebody notices something unusual about their breast or about their body. And are thinking, should I go? Should I not go? They're bargaining, they're justifying, oh, this could be fat, this could be that. And then it starts with mental torture. Or what if they say it's breast cancer? So much mental torture at the pre-diagnosis stage. And women and patients, and even men, need help. Then you go to the point where he's been able to go to the hospital and they say, go and do an investigation, a mammogram, a breast ultrasound scan, a biopsy. A lot goes on from the time they do it to the time they get the results. And then there's the diagnosis. How is this communicated? Does the patient want to? How would the physician do it? What effects would it even have on the care and treatment plans? Then there's treatment options. What do I do? Do I cut off the breast? Is chemo? Which one works for me? Influences of these things, money. Even when I want to do it, do I have enough money? Is it sustainable? A lot goes on at this stage. Then it comes to the treatment process. Depending on the type, the stage, a lot goes on. From the cancer itself, from side effects of medication, from the treatment, getting people to take you, support you, continuing, there are needs there. Then sometimes people are lucky and they go into remission or they're cured. But then even after survival, there is always a problem. There's anxiety. What if the contralateral breast is affected? What if it recurs? What if there is so much mental trauma and torture amongst patients? Then there could be the other group of people who may not receive a cure. They may go through treatment, but treatment would fail. There are needs there that need to be addressed. Then probably those who are presented late or have failed treatments, how do you support them? How do you provide comfort care for themselves and their family? The neuro symptoms that come up. How does this breast cancer patient receive support for this? What is the way forward for themselves, for their families, their future? Then death comes in. And then there's bereavement. Does the cycle continue for the family they've left behind? All these are stages breast cancer patients go through. And there is no stage. Please let me know if there's any stage that there may not be a need. And so breast cancer care has needs at all points. And palliative care provides those needs in conjunction with other forms of care. So when and why is palliative care needed in breast cancer? When? At every stage. Previously, we would bring palliative care in at the end. But if you look at this diagram, we're saying that palliative care is about prevention. I see a patient. She has children. It's genetic. What do I do? How do I advise her children on measures to prevent breast cancer from occurring? Diagnosis. So when you look at this, the area above the zigzag in green shows curative and life-prolonging care. And the area painted yellow shows palliative care. We've moved from that picture where you had a straight line. This is a zigzag because the need for palliative care can come in right at diagnosis and may come up or down depending on what the needs are. Sometimes the need for palliative care is high, sometimes it's low. But you realize that as we approach end of life care, then the need for palliative care becomes more. Unfortunately, people refer patients at that tail end. And so a lot is lost at the beginning. I've mentioned that palliative care should be integrated right at the diagnosis of breast cancer. And even when curative measures are going on, there could be significant symptom burden or distress in patients. And palliative care can come in because palliative care is addressing all the needs of a patient, sometimes psychological, sometimes it's just informational needs that our regular busy clinic schedules will not allow. But they are needs that have to be addressed and should not be overlooked. And there are benefits of early palliative care integration. One, there's better symptom management right from the start. There's improved patient and family coping. They get used to palliative, the team, and they don't become the angels of death who come in at the end. It becomes a way of supporting the patient. Somewhere in Texas, the palliative care unit of an institution changed the name from palliative care unit to supportive care unit. Every other thing remained the same. Doctors, the nurses, the time, whatever they did remained the same. It was noticed that there was a 30-fold increase in referral patterns because physicians themselves were more willing to send a patient to a place which had the name supportive care. And truly, that's what we do. We support the patient. And so if there's benefits, let's not just be deterred by the name. Hopefully, as time goes on, we may change the name. But if you understand what it provides to the patient, the name should not be a deterrent. There's enhanced communication and shared decision-making because you're able to talk outside their regular routine. It's a multidisciplinary team. People sometimes forget to ask certain things at one review, but may remember at another and bring it up for discussion. There's reduced psychological distress, and there's higher patient satisfaction according to studies. And there's avoidance of aggressive, non-beneficial treatment near end of life because patients understand and know what to expect and have enough time to plan, to do advanced care plan and then plan ahead, rather than a very short time to plan a whole life that they've lived for many years. So the challenges to early integration is what I have talked about, misconception of palliative care as only for the imminently dying. And unfortunately, as healthcare workers, we would not refer patients that we think need palliative care because we see it as a sign of failure. Oh, why are you sending to palliative care? Aren't we still caring for the patient? But it's referring to palliative care doesn't mean you are giving up or you are giving over the patient to us. It's a collaborative care, and we are helping to meet the needs of a patient that you may not ordinarily be able to meet in one setting or a short review time. Our numbers. So sometimes there's inadequate professionals and resources to provide palliative care, but I have to say that currently palliative care provision has to be done by all health workers. at least basic palliative care, knowing what palliative care and talking about palliative care should be known to health workers. We should be able to identify a patient who has palliative care needs and make the necessary referral if we can't manage there. And so saying that palliative care should be started at diagnosis is not always sending them over to the specialized or tertiary care team. It is actually ensuring that any form of suffering that they may have is holistically managed, even if you're a primary care provider. And sometimes cultural factors and communication barriers. For instance, in our setting, most people are very uncomfortable and unwilling to talk about death and dying with the living. And so even doing advanced care planning may be challenging, and most people would like to sway from it. But it's a conversation that has always been proven to help, and it makes bereavement process even well handled for family. So remember Mrs. TK we were talking about. We're coming back to her. So it's 2 years down the line, and Mrs. TK is still alive. She's been doing her herbal preparations, but there's been significant weight loss. She has a malignant ulcer of the breast. She's dressing the ulcer at home because she attempted to go to the hospital on 2 occasions, and she was shouted upon because she had stayed at home. She was getting looks from people who didn't want to sit by her. Everybody was asking her questions, and being a clergy, it was too much for her. And so she thought, look, I had seen what the nurses were doing. I can do it at home. Even socially, the numbers in her congregation started plummeting. People started leaving. Because if you're really a woman of God, why are you still suffering? Why haven't you prayed for healing on this thing? Could you have done something bad? And that's why you've had this as a punishment. She was going through a lot. Now, her husband was distressed. He was unproductive at work. His boss was complaining because he constantly had to take time off and take care of his wife. Their 6-year-old would stay up whenever she was in pain, and she started behaving like somebody who was always in pain and touching her breast, and it was affecting everybody in the family. His wife was always miserable, didn't want to talk to anybody, didn't want to do anything. There was no joy at home. And so she had symptoms of malaria one day and reported to a primary care facility where she meets Dr. P. Dr. P attends to her and uses that opportunity to educate her about palliative care, telling her that once she is still alive, there's nothing, nobody can say that there's nothing we cannot do. And so there's still hope for you. You could be assessed, and even if curative measures are not an option, you could still have symptom control. So she reports the palliative care team has a long session with a multidisciplinary team. Collaborative care is done, and she's given a referral to go to the surgeons and oncologists just to see if there's something that could be done. Curative measures are said not to be possible at that stage, but then she and her family start receiving palliative care. We'll talk about what they received as we go along. So why is palliative care in breast cancer crucial? Because breast cancer patients face a high burden of needs. Most of the time, physical needs, which may be things that symptoms resulting from the disease like pain, fatigue, nausea, breathlessness, lymphedema, are usually managed. So long as the patient is coming to the hospital, they are usually managed. However, there are other needs that may go unnoticed and sometimes are not given a lot of attention. A patient would be asked to come to the hospital so long as he's receiving medication or there's a physical need that can be addressed. But the minute, quote and unquote, there's nothing that can be done for that patient, review dates stop. They are no longer asked to come in some instances. And then the patients are left wondering what to do. They are still alive. There's no surgery, no medications to cure them. But what did they do when death hasn't come for them already? Or should they concentrate about just waiting on death? No. There could even be complex psychological needs that breast cancer patients face. Emotional distress, fear, pain, distress. Sometimes there are body dysmorphic concerns. They may have lost so much weight, And in our setting where weight loss is a big deal, everywhere you go, they're asking you, why have you lost weight? Are you okay? So patients no longer want to go into the social space. They are wearing loose clothes. They don't want to do the things that used to bring them joy. They become depressed. This lady couldn't even go to church because she just couldn't stand the questions that would come. Breast cancer patients have sexuality issues. There are couples who do not want to engage sexually because of fear of harming them, or there's probably no energy to even engage, and they are afraid, and so much goes on. But how many times do we, as physicians or nurses, ask about sexuality issues and the effect of breast cancer on sexuality, on their marriages, on their relationship with their spouses? There's social withdrawal. There's stigma. Friends don't want to even visit. Friends don't want to go into their homes for fear of getting breast cancer through the air, which we know is not possible. There's lost hope. There's also spiritual distress and existential concerns. God, why me? Why is this happening to me? My faith. I'm having so much faith, and yet I see my body going down every day. And it's a struggle and it's a fight. And like Mrs. TK, she even lost members of her congregation because she was sick, something that was by no fault of hers. There are people who think that their sickness is as a result of a punishment for a wrongdoing. These are things that breast cancer patients go through. And yet, we are fixated on physical symptoms only. There's family and caregiver burden. Family members have to take up the role of primary caregivers, something they have not been trained for, something they never saw it coming. Some people do that to the detriment of their own health. They never get to go for reviews. Mrs. TK's husband had elevated high blood pressure where we just checked at the clinic. And sometimes it's so hard for them. They are being bashed at work. They can't have a social life. Their children are worried. They have no one to take care of them, and it's a problem. Sometimes it's just unmet informational needs. You say cancer, and you expect everybody to understand what cancer is because it's a common word. But not everybody understands what cancer is. They may have heard it, but don't understand. You may be speaking to them, but are they understanding what you're saying? You may be using jargons and talking about radiotherapy and chemotherapy and metastatic disease. Do they understand it? And this is the time where they Google anything or they go on the internet and there's a lot of information and they are reflecting on past experiences. And they are also having what I call the theysay.com. Don't eat sugar, don't eat carbohydrates, don't do this. And they are having nutritional deficiencies because the theysay.com are telling them things that should be coming from professionals, but we're never asking. And they are battling with all of these. These are unmet needs in cancer patients. And so for health workers, it's important that we explore all these dimensions. Spiritual. On one of your reviews, just ask them how they are doing. Has it changed your belief system? How are you coping? Your faith. How is it affecting you mentally? How about the home, the marriage? You would be amazed at what would come up. And pain is one of the commonest symptoms that breast cancer patients face. But we know that pain is multifactorial. In palliative care, we have something we call total pain, where we say that pain is intertwined. There's physical, social, spiritual aspects that affects the physical component of pain. And so sometimes it's not about just coming in and saying that the morphine we're giving you is not working. Let me increase the dose. No, it's about doing what we call a total pain evaluation and finding out how they are going through spiritual pain because they feel
Dr.
that God has given
we'll
upon them.
have 10 more minutes.
Thank you very much. So there are many ways, and opioids are the mainstay of management. They have fatigue, which is usually multifactorial. A very common symptom may be due to anemia, depression, poor sleep. And the management is always treating the underlying cause, giving them ways of conserving energy, and psychoeducation. Breast cancer patients go through nausea and vomiting that may be due to disease progression, treatment side effects. It's important to look at these because it causes a lot of discomfort for them. Breathlessness is another common symptom, and I like to talk about this because opioid phobia is very common amongst us. There are patients who studies have shown that low dose opioids, example, morphine, is actually used in managing breathlessness. However, patients are put on opioids and people will take them off. Breast cancer patients, doctors will take them off because they are afraid of respiratory depression. Meanwhile, they are going through pain and are on safe doses of opioids that would manage the pain. And we even know that low dose opioids, sometimes even in the absence of pain, can be used to manage breathlessness. Lymphedema, body dysmorphic features, how are we helping the discomforts after a surgery or radiotherapy? We need to be able to manage them appropriately than just to look at other aspects and leave it. Malignant wounds, example, fungating breast tumors, also a big problem for breast cancer patients that have to be looked at. How are they managing the wounds and how are we supporting them? Constipation, a very unbearable and uncomfortable symptom, which may be from the opioids we are using to control their pains, from the fact that they're not eating well, they are not mobilizing. And so putting patients on prophylactic laxatives if they are on opioids or treating constipation is very important. We've talked about psychological distress. Suicidal ideations are common. We need to assess these in breast cancer patients and address them. The social impact. The social impact is vast, is large, and we need to talk about that. We've talked about spiritual care. How do we do it? Assess. Some multidisciplinary teams may have chaplains, but where there isn't, you can find somebody according to the breast cancer patient's belief and help them to encourage them in their faith-based things. Family support is important. Palliative care looks at not just the patient, but their family. So it's important that in some of our reviews, we turn to the family and see how they are coping and see how we can help them. Also to be able to meet their needs, because sometimes there's a lot of information that family caregivers can give, but we never engage them. I put this up because it's so important, and you would think it's common, but to date, we still have people who come to our clinic at the tail end and say that I didn't say proceed with this treatment because of the way the news was broken to me. And so quickly, I want us to look at the SPIKES approach in breaking bad news, SPIKES. When you're breaking bad news, just look for a good setting, a quiet place on the side. Ask the patient for their perception. What do you think is going on? What do you know? What have you read? If there's bad news after listening to their perception, let them know. Give them a warning shot that I'm afraid I have some bad news. Would you like to listen? How much do you want to know? Do you want anybody with you? Then you give the knowledge, and that is where you tell them what is going on in plain and simple language that they can understand. Given knowledge comes with a lot of emotion, so you empathize with them. And after that empathy, you summarize and strategize and plan and listen to what they have to say. And the summary is from the patient, asking the patient to tell you also what they have heard you say. These are some voices from real patients and how they feel in their breast cancer journey. So who provides palliative care? Everybody. It takes you and I to identify the need and reduce the suffering of patients who are going through a lot of diseases. Now, I mentioned that it's a multidisciplinary team. So a palliative care team is not just one cadre of specialty. It's a multidisciplinary team, pharmacists, doctors, nurses, dietitians, volunteers, oncologists, surgeons, all coming together to provide care. So I'd like to end by using this animation, and I got it from one of our groups shared by a doctor. Palliative care can be likened to preparing for rain or a stormy day. And it says palliative care is the umbrella, not rain. So in the first picture, I talked about late palliative care referral. So a couple comes to see a doctor late, having been referred very late for palliative care. They step outside and it starts raining cats and dogs. The doctor has to go through the rain to give them an umbrella. It says, here, this will help. But it says, thanks. We wish we had had this earlier. On the other hand, early palliative care is giving information. They may not need it at that time, but giving information to a patient and telling them about what they may expect on the journey. So you may not need this umbrella yet, but we're just giving it to you just in case it gets stormy. when they get outside and they meet the storm, at least they have something that can help them, or they may have prepared. So it says, so glad we had this when we needed it. So in conclusion, I say palliative care is a fundamental human right and an essential component for comprehensive breast cancer care. We need to maximize the quality of life for patients. And saying that there is nothing we can do for a patient with breast cancer must never be an option. There is always something that can be done. Thank you very much.
Thank you very much, Dr. Sapon, for a very lucid presentation. I wouldn't attempt to summarize, but suffice to say that, palliative care is not hospice care. I mean, there's been this misconception that, palliative care is synonymous with hospice care. You have explained it to us. We have appreciated. It's also important for us to know that, it's a multidisciplinary approach to managing the patient, and each and every health professional should be involved. It's not an assignment or an approach that should be driven by just one person. I think we'll have a bit more time at the tail end to invite some questions and comments. So thank you so much for the presentation. I have really enjoyed it. Yes.
Thank you too.
Yes. Our next topic is breast cancer in pregnancy. And as you are aware, pregnancy and any complication that is elicited or noted during pregnancy causes a lot of distress for both the expectant mother and the doctor. So long as, we are beginning to see breast cancer in the younger age group, and at the same time, quite a number of women, are professionally engaged and therefore defer their reproductive life, we are likely to have quite a number of these cases come up because it will usually peak around after 40 years. But with the technology in conception and so on, a lot of our women, especially those who are very enlightened, are not at all in a hurry to go through their reproductive life. And to be diagnosed with breast cancer whilst you are pregnant is no good news for anybody. For us to be taken through this and for us to appreciate that it is not a death sentence, we have someone who has been dealing with this on a daily basis to throw a bit more light and give hope. We have, a person to do this who is a consultant general surgeon and senior lecturer in the Department of Surgery of the University of Ghana Medical School. The person also serves as head of the Surgical Unit 2 at Korle Bu Teaching Hospital, where she has played a pivotal role in surgical education, clinical service delivery, and mentorship. She holds a BSc and MBCAD from the University of Ghana Medical School and has earned fellowships from 3 major surgical bodies. That's the West African College of Surgeons, the Ghana College of Surgeons, and the American College of Surgeons. She has developed a special interest in breast cancer management and is recognized for her extensive experience and leadership in this area. She has also authored numerous peer-reviewed publications in breast cancer and contributed a lot in the area of evidence care in this area. Without much ado, I would ask you to, support me to welcome Dr. Florence Dede to do the next presentation. Doc, we are all ears, and thank you for accepting the invitation to do this presentation. Thank you.
Thank you very much, Dr. Norte, and thank you for the very nice introduction. So I think I can put it on slide. Sure. So my topic is, we are looking at breast cancer in special situations, and my topic is breast cancer in pregnancy. So we've just listened to palliative care in breast cancer, and I'm sure we've all learned a lot from that. I think I picked these two pictures from the internet, but I think Dr. Norte has already alluded to what I wanted the pictures to show. When someone is pregnant, it's all joy, it's all expectancy, it's all happiness. You're thinking about the new life coming and all that. And I mean, definitely the breasts are going to play a role in nurturing that child, breastfeeding that child. But then when we look at breast cancer, this quotation says it's about focusing on the fight and not the fright. So clearly we can see that that is not happiness, that is not joy, that is not something you're expectantly looking for. It's all about fighting and fright, and it's not a pleasant thing to go through. So even when you have breast cancer in a non-pregnant woman, it's a whole big deal. It's bad enough. So when we can imagine that if we are now having breast cancer in a pregnant woman, it causes a lot of emotional turmoil. Instead of looking forward to the future, you wonder, am I even going to be there to be able to take care of this child? You wonder, am I going to be able to breastfeed the child? Am I going to be able to nurture this child well? So it's a very traumatic period for any woman who is diagnosed with breast cancer in pregnancy. So I think we need to bear that in mind. The lady who talked about, I'm sorry, I've forgotten the name, but she talked, I think it's Abna, talked about at times the way that physicians relate to patients and how it can impact on the decisions they take. I'm sure when you listen to the doctor's side of the story, it's a whole different story. We all know that, but we still need to keep making the efforts. And we need to remember that someone who is pregnant and has breast cancer has, should I say, double trouble. They are a lot more confused and emotionally disturbed. So we need to really, what's the word I should use? We should go to extra lengths to try and handle these patients. So my outline, just a brief introduction. We'll look at some case studies, how breast cancer in pregnancy presents, how we make a diagnosis, the treatment options, and then we would conclude. So breast cancer, we know, is the commonest female cancer worldwide and also in Ghana. But it's also the most common malignancy during pregnancy. So it said that 1 in 3,000 pregnancies are complicated by breast cancer. So it's not so common, fairly rare in pregnancy, but we do come across it, and we need to be abreast with how to manage them. Of all breast cancer patients, we would say about 7% of them could be pregnant, especially in our part of the world where we tend to diagnose breast cancer earlier, so in the reproductive age group. So we tend to see more of that because we have earlier breast cancer. And breast cancer in pregnancy is also referred to as gestational breast cancer or pregnancy-associated breast cancer. And it's basically breast cancer which is diagnosed during pregnancy, but also in the first year post-delivery or during lactation. So not just during pregnancy, but should I say around pregnancy, during and after. We know that the incidence is increasing. I think Dr. Norte mentioned that as well, because more women are delaying childbirth. So we know that breast cancer increases as we grow older. And so if women are delaying childbirth to get pregnant later, then there's a higher risk of also having breast cancer in that same period. And I've also already said that breast cancer is also increasingly being diagnosed in younger women. Today at the clinic, I saw a few women in their 20s, a lot more in their 30s, some in their 40s. So if we are diagnosing breast cancer in these earlier age groups, then it stands to reason that we may get some will come also pregnant or have just had their children. For breast cancer in pregnancy, the gestational age influences the treatment options that we have, because it's not everything that we can do during every trimester. So in some of the trimesters, some of the treatment options or modalities may be contraindicated. So the gestational age is important because it influences how we are going to treat the patient. But the goal generally is for the safe delivery of a term baby. And we want to do that without worsening the patient's prognosis. So you want to make sure you treat the patient as best as you can for the best outcomes relating to the breast cancer, but also be able to achieve the safe delivery of a term baby. And it's actually known that good maternal and fetal outcomes are possible without having to terminate the pregnancy. So decades ago, maybe when I was a student, when somebody comes with pregnant and with breast cancer, one of the first things that would be talked about is terminating the pregnancy or waiting for the patient, if she's close to delivering, to deliver before you treat. But now we know that we can do it alongside the pregnancy, and just terminating the pregnancy alone would not actually increase or improve the outcomes in most situations. However, we know that we still can have poor outcomes in pregnancy-associated breast cancer. And that can be attributed to the fact that they tend to present late. So actually, when we even take breast cancer in non-pregnant women, I think Abner referred to the fact that about 70% of them are being diagnosed late. Unfortunately, with pregnancy, it may even be more because there are diagnostic delays because of the patients themselves may not present early because they may feel like whatever they are experiencing is because of the pregnancy. We know pregnancy will give some changes in the breast. And so when they begin to feel the breast cancer symptoms, at times they just attribute it to the usual breast cancer changes and may not seek help early. At times too, they do come to hospital, and unfortunately, we the healthcare providers also miss the diagnosis, again, because of those same changes. So clinically, as well as even radiologically, it may be difficult to interpret some of the findings that we have. So that can cause delays. And then there's also the limitation in giving certain medications. As I've said, it's not everything you can do in every trimester. So all that can contribute to late stage in diagnosis and ineffective treatment, which can give us poor outcomes. For treating a breast cancer patient who is pregnant, a multidisciplinary approach is crucial to be able to attain good measures. So definitely the surgeon and the oncologist, as well as the obstetrician, the neonatologist or the pediatrician, and then all the others that we involve, the nurses, the psychologists, palliative care, if that is indicated. Definitely from what we've just heard, that would be indicated as well. So it's important to involve as many people from different disciplines so that we can all put our heads together and offer the patient the best outcome. And here we know we are not only dealing with the woman, but we are also looking at the baby, getting a good outcome from there as well. All right, so a lot of what I'm going to say is based on a paper that we wrote about 5 years ago, was published on the experiences and challenges in the management of pregnancy-associated breast cancer at the Kolebu Teaching Hospital. And we reviewed 4 cases. I'll go through all those 4 cases and then we basically discussed it. So for case 1, that was a 33-year-old woman who was seen in 2016. At that time, she was 8 weeks pregnant and had noticed a painless left breast lump and bloody nipple discharge 5 months prior to presentation. When we examined her, she had a 6-centimeter lump and mobile axillary lymph node. Was clinically staged as a T3N1 M0 after all the investigations. And then a biopsy proved an invasive carcinoma, no special type, also triple negative and grade 3. So it was discussed at the multidisciplinary team, and they recommended an upfront mastectomy and axillary lymph node dissection, followed by chemotherapy. In those days, we were doing CAF, so cyclophosphamide, hydramycin, 5-fluorouracil in the 2nd trimester, because we cannot give chemo in the 1st trimester. So following an uneventful completion of, so she had the surgery, she had chemo, and then successfully induced at 36 weeks gestation, delivered a healthy 2.7 kilo female. She then went on to have radiation to the chest wall and supraclavicular region after delivery. At her 8th year, I actually saw this lady for review last year, and at her 8th-year follow-up, there's no evidence of disease recurrence, and the child has normal developmental milestones. Second case is a 38-year-old who presented at 5 months gestation in 2017. She had a 2-year history of a right breast lump, core biopsy invasive carcinoma, no special type grade 2, hormone negative, HER2 positive. She was staged as a clinical T3 N1 M0. Per the MDT recommendation, she completed 4 cycles of CAF, and that was at 32 weeks, with a partial clinical response, about 50% decrease in the size. She then went on to have a joint cesarean section and mastectomy with axillary clearance at 36 weeks, and delivered a healthy 2.4 kilo female. We asked her to omit breastfeeding as she had to continue her chemotherapy, did her 4 other cycles of paclitaxel with Herceptin or trastuzumab, and this was followed by radiation. 2-year review, there was no evidence of any recurrence, and the child had remained healthy. Unfortunately, she's been lost to follow-up. The third one was a 26-year-old we saw in 2018 with a year's history of a left breast lump and a family history of breast cancer in 2 first-degree relatives. She initially presented with an 8-centimeter lump, but there was no palpable axillary node. Unfortunately, she defaulted for 7 months and returned with an extensive locally advanced disease. That is when she had a biopsy done, invasive carcinoma, NST grade 2, hormone positive, HER2 negative, and Ki67 was more than 20%. Unfortunately, she defaulted again and returned 2 months later, newly married and 9 weeks pregnant. She went on to develop a pleural effusion within a few weeks, for which she had a chest tube passed and pleurodesis. The disease was now staged as a clinical T4C N2 M1, and we started chemotherapy at the start of the 2nd trimester. So she completed all 6 cycles of a palliative chemotherapy by 34 weeks gestation with partial clinical response. Labor was induced at 38 weeks. She delivered a healthy 2.5 kilo female. She also omitted breastfeeding and was started on tamoxifen. At 1 year, there was no evidence of relapse. The child remained healthy, but after that, we ended up losing the patient, and unfortunately, we've not been able to follow up on the child. The 4th case, a 33-year-old who presented in 2019 with an ulcerated left breast lump. She was 16 weeks pregnant. Core biopsy showed an invasive carcinoma NST grade 3, hormone ER positive but PR negative, HER2 positive, and Ki67 was more than 50%. Her metastatic workup found liver and lung mets, and so she was staged as a T4B N2 M1. MDT recommended 6 cycles of CAF prior to delivery. Unfortunately, following the 4th cycle, she developed uncontrollable generalized tonic-clonic seizures without any evidence of eclampsia. So we got a multidisciplinary team involved. She became semi-conscious, had incoherent speech, nystagmus, saturations were down. She was started on mannitol, dexamethasone, phenytoin, midazolam on suspicion of brain mets, and we attempted an MRI to confirm that, but it couldn't be done because of the uncontrollable seizures. So after 24 hours of status epilepticus, her next of kin gave informed consent for an emergency CS. Pre-delivery ultrasound showed a 33-week fetus with severe intrauterine growth restriction. The mother continued to deteriorate and died 72 hours after surgery, but a 1.2 kilo male was delivered and admitted to the NICU for 3 weeks due to the low birth weight and prematurity. The baby survived and at 3 months was weighing 3.7 kilos. So these are 4 cases just to illustrate what we've been doing, how breast cancer in pregnancy is treated. So now I'll go through the presentation, the diagnosis, and the treatment briefly. So really, they present in the same way as patients who are not pregnant. So similar presenting symptoms, most commonly a lump, at times a swelling, at times skin changes, a nipple discharge, an ulcer. It can be any of the symptoms, but most commonly a lump, as occurs in non-pregnant females. But the problem, as I've already mentioned, is that it may be ignored either by the patient or misdiagnosed by the healthcare professional because of, one, the young age, because often when we see a young person with a breast lump, we don't even think about, or malignancy is way down on our differentials, and we may actually miss the diagnosis. Or then it can also be ignored or misdiagnosed because of the pregnancy and or lactation-related symptoms. So the breasts may be engorged, the breast may be a bit painful, you may feel lumpy, and it may be difficult to determine if there's what you are feeling is actually something concerning. So because of these reasons, it can either be ignored by the patient or misdiagnosed by the healthcare professional. And like I said, even the investigations can also be difficult to interpret. So because of these reasons, it's commonly diagnosed in either advanced or metastatic stages. And as you realize, all the patients I presented, we didn't have any early presentation. They were all advanced or metastatic. Unfortunately as well, it's been noted that aggressive subtypes are rather common in pregnancy. So triple negative breast cancers, HER2 enriched, which are more aggressive than the hormone positive ones, they tend to be a bit more common in pregnancy. And these aggressive subtypes tend to progress quickly, so they may present with advanced or metastatic disease rather quickly in the course of the disease. For the diagnosis, it can be challenging because of the anatomic and physiologic changes in the breast, and these can mask detection of abnormalities both clinically and radiologically. But then we still go about trying to make a diagnosis in the same way. So we use the triple assessment. We still do a clinical assessment, and we shouldn't relegate breast cancer to the background. Anybody who has a breast lump, there's always the possibility that it can be a breast cancer. And so even in pregnancy, we need to remember that as well and assess the patients accordingly. Radiological examination, because of the pregnancy and the risk of radiation damage to the fetus, we prefer to use an ultrasound. But a mammography can also be done if it is necessary. The ultrasound doesn't give you all the information you need. So in that situation, the radiologist should be made aware so that the fetus can be shielded and we can go ahead with the mammography. But usually the first option is to do an ultrasound. And then also you should do the biopsy. So that one, usually the pregnancy doesn't really affect it. So the pathological assessment, which is the third part of the assessment, is do a biopsy. Often, if we can't do a blind biopsy, what we tend to do is an ultrasound-guided biopsy. So again, that is safe in pregnancy and can be done. In terms of doing a metastatic workup, a CT scan would be contraindicated because of the radiation. And so usually, although these days we prefer to do a CT of the chest and the abdomen, we would rather do a chest X-ray with shielding of the fetus and also an abdominal ultrasound. And then after delivery, we can do the CT just to be sure that we haven't missed anything. MRI without contrast can also be done for the detection of metastasis, but we should do that with caution in the first trimester of pregnancy. As I've said, CT and radioisotope scans are contraindicated. So anything that cannot be done during pregnancy can be done when the patient has delivered, but at least we need some baseline information. And so a chest X-ray with shielding of the fetus and an abdominal ultrasound are usually good enough to give us the information that we need. So when it comes to treatment options, like I said in the introduction, the maternal and fetal health should be considered. So we are not treating the mother to the detriment of the fetus or the fetus to the detriment of the mother. We are looking at both of them and trying to get the best outcomes for both of them. So we are looking at how we can get a healthy baby delivered at term, but also be able to treat the breast cancer to get a good outcome. So for breast cancer, usually we talk about 5 modalities of treatment: surgery, chemotherapy, radiation, immunotherapy, and hormonal therapy. Surgery is safe in all trimesters. We know there can be a slightly increased risk of going into preterm labor, especially in the 2nd trimester. So usually if we have to operate, then definitely we make the anesthetists aware, and they may give some tocolytics to cover the period of the surgery. But all in all, surgery is quite safe for all trimesters. And we tend to want to do a mastectomy, especially if it's early. So if you see someone who is 6 weeks pregnant and you want to operate, if we did a breast conserving surgery, we probably are going to finish all our chemotherapy, and then we'll just have to sit and wait till the patient has delivered before we can continue with radiation. So for that reason, if you are operating very early in the pregnancy, then you would want to go for a mastectomy rather, so that hopefully if it's early disease, the patient may not need radiotherapy. But otherwise, if you are operating later and your treatment is such that it will take you till after delivery, then if there's an indication to do breast conserving surgery, you can still do it. So pregnancy in itself is not a contraindication to breast conserving surgery. Chemotherapy, the 2nd modality of treatment, is safe in 2nd and 3rd trimester. So definitely not in the 1st trimester when we have all the body organs being formed. We want to avoid it then. But starting from the 2nd trimester, 3rd trimester, chemotherapy is safe. What has been studied the most is the cyclophosphamide adriamycin 5-fluorouracil. So we use that. Some studies, a few studies have looked at taxanes and said they are safe, but most studies will stay away from taxanes, also stay away from methotrexate. So usually we would stick to using CAF, and that is actually what we used for all our patients. The other thing is to, usually you don't want to go beyond like 32 weeks, maybe maximum 34 weeks with the chemo, because you want to give a safe interval between when you finish chemo and when you are going to deliver the baby. We know chemotherapy can cause immunosuppression, reduced platelets, reduced white cell, reduced HB, and you don't want to have a woman having to go through delivery, be it by SVD or by cesarean section with all this immunosuppression. So you want to finish your chemo in good time for them to recover before delivery goes on. So usually from beginning of 2nd trimester, 13, 14 weeks, up to about 32, 34 weeks, you can safely give chemotherapy. But then we know that there can be some growth restriction of the baby and also preterm delivery associated with chemotherapy administration. So it's not like everything, it's not 100%. So while we are giving chemo, we need to be monitoring the baby, doing serial scans, ultrasound scans, to make sure that the baby is growing and everything is safe with the child. So ultrasound monitoring of fetal growth is recommended during chemotherapy. Radiation, immunotherapy, trastuzumab, and then hormonal therapy are all contraindicated during pregnancy. So while the woman is pregnant, usually we'll do surgery, we'll do chemotherapy, and then if we have to do any of the others, radiation, trastuzumab, hormonal therapy, we have to defer that till after delivery. But because chemotherapy is usually 8 cycles, that takes about 6 months. And normally we would start from the 2nd trimester. So often you'd be able to, you don't have to delay, or there's not much of a wait, trying to wait to be able to continue with the other treatments. So although they are contraindicated, you can give them after the patient has delivered, and often there isn't much of a waiting period. Where there is, then we may have to make exceptions to how we manage the patients. All right, so I think I've alluded to this. The sequence of treatment and delivery must be planned in consultation with oncologists, with obstetricians, as well as with pediatricians. So we've talked about the fact that we need to stop the chemotherapy 32 to 34 weeks. So we have at least 3 to 4 weeks before delivery. And the goal is to deliver at 10, that is 37 completed weeks. But we can decide to do it earlier if for some reason we need to proceed with some treatment. So let's say the patient is HER2 positive, is not responding to the initial chemo you are given, and you need to start the trastuzumab. You cannot give it during pregnancy. You need to wait till the patient has delivered. And then you can start the trastuzumab. So So you could actually decide to deliver the baby a little earlier so you can give the patient the benefit of getting that treatment. So that's all. The patient is not responding to the chemo you are giving. And so you need to tend to switch to something else, which is not safe in pregnancy. Then you may have to consider delivering the baby earlier. And if we have to do that, then we need to look at fetal lung maturity and also be sure that NICU services are available. So definitely obstetrician inputs, pediatrician inputs, oncologists. I talked about one where we had to do a simultaneous mastectomy and CS, so surgeons also coming in. And then, of course, the psychologist and all that. This is all a lot for the patients to handle. So we need to make sure all that is covered so that holistically we are managing the patients. So I've mentioned already, allow 3 to 4 weeks after chemo so that we minimize the complications from hemorrhage and from infection. And then also the mode of delivery can either be by SVD or by CS. Usually if it's SVD, it's induced because you don't just want to sit waiting for the patient to go into labor. So let's say you finished your chemo at 32 weeks. And you want the patient to deliver so that you can continue with treatment. So if you finish at 32 weeks and you are just waiting, the patient, we all know, can go into spontaneous labor at 40 weeks, 39, 40, even 41, 42. So we don't want to wait because it would waste time and the patient will not have the timely treatment that they need. So often, once we've timed everything, the labor is induced if SVD is indicated. Otherwise, you plan to do a CS if CS is indicated. So breast cancer by itself is not an indication for CS. You can still go ahead with SVD, but usually it should be induced. Breastfeeding, unfortunately, is also contraindicated during chemotherapy, immunotherapy, hormonal therapy, or radiation. So you notice from the cases that I presented that we didn't allow the patients to breastfeed so they could continue with their treatments. If it's surgery you are having after delivery, then you can go ahead and breastfeed once they are not having any of these other treatments. But if any of these are coming in, then we have to hold on to breastfeeding and advise the patient on other means of feeding the child. So the multidisciplinary approach is really important, and it should start right from the time of diagnosis so that we know what to do. We shouldn't see the pregnant woman and say, wait till you deliver. We've had a few like that. When I went, they said I was pregnant, so I should wait. When I deliver, then I come. That is not the right thing to do. We need to, right from the beginning when we've made, even without the patient being pregnant, we use a multidisciplinary approach. So how much more for a pregnant woman who needs even more consultation? So once we make that diagnosis, let's get the necessary people involved, the oncologists, the surgeons, and as we go along, the pediatricians, when we are getting to time for delivery. It's really important. Psychological support, I think I've already talked about that a bit, and I wouldn't belabor the point. Palliative care, we've just had 30 minutes of palliative care, so we know the importance and the use and how effective it is for the patient. So in the setting of pregnancy, if the patient comes with pregnancy, with breast cancer, palliative care is useful, especially for the metastatic disease, but even for other advanced stages as well, because the patients can benefit from that. So we know that the outcomes can be good for the mother, especially if it's diagnosed early, just like for the non-pregnant woman. If we pick breast cancer early, we treat it effectively, the outcomes are good, the cure rates are high. Outcomes for the baby are also good from the various studies that have been done, even when chemotherapy has been administered during pregnancy. And long-term follow-up has not as yet revealed any adverse effects on the children. So to conclude, breast cancer in pregnancy has similar presentation to non-pregnant women, but certain investigations and treatments are contraindicated, and therefore diagnosis and treatment can be rather challenging. However, effective treatment, including chemotherapy and surgery, can be administered during pregnancy. And as I've said, we can continue with the other modalities of treatment after delivery. Outcomes for mother and baby with effective treatment are actually good. And it's important to remember we need to approach with the multidisciplinary. We need to use the multidisciplinary approach because it's crucial to make sure that the best outcomes are achieved for both mother and baby. All right, so those are my references. Thank you. I'll be happy to answer any questions.
Thank you very much, Dr. Dede, for the message of hope. As you are aware, I mean, nobody is spared. In the past, we all thought cancer is a problem of the old folks. You know, cancer, especially breast cancer, you know, is not something you should think about during pregnancy, but it's been demonstrated to us with the cases presented that the problem is really real. But the good thing is that, you know, that's no death sentence. The challenge really is for us to be vigilant, to be sensitized to the problem so that they are picked up early enough, you know. Like our presenter said, in the past, a pregnant woman reporting with breast cancer was automatically going to have to lose the baby because they couldn't see how that was going to be compatible with cancer treatment. So a lot of progress has been made, but I'm very much excited by the fact that we are going the modern way, that is multidisciplinary approach to all that we do. Medical knowledge and expertise do not reside in one person. We've done the 1 man 1,000 for far too long, and joining hands and heads together to manage our cases, you know, would always positively impact outcome. So at this juncture, I would pause, and then we would invite questions. I'll go to the Q&A. Please be specific on the presenter you want to answer your question so that we direct it accordingly. So I'll go to the Q&A and read out some of the questions. Yes. For now, the first one is from one Cosmos Arthur. Says, please, how can a nurse stay current with the latest evidence-based practices in palliative care for breast cancer? Then there is an anonymous attendee who put this question: apart from Kolebu Teaching Hospital, which hospitals do we have a palliative care team for referral? And then, are there any more? I think we have 10. Let me see. Yes. And then the other one is a request. Organizers should kindly share presentations. And then there is another one. Please, I want to ask whether pregnancy with breast cancer or those with breast cancer, do you do mastectomy? I think it's been explained, it's been answered. So it's a moot point for now. Shall we hear from our presenters? You know, because we've had a couple of questions on palliative care. So, Doc, can you speak to that, Dr. Sapo? And
Yes.
then Dr. Dede will come in later. Yes.
Right. Thank you very much, Dr. Naughty, and thank you, Cosmos, for the question. So palliative care training programs occur all the time. The Ghana Palliative Care Association puts up training programs from time to time. But what I can say is that you can start reading about palliative care on the internet. Also joining any of the Ghana Palliative Care Association groups. The Ghana Palliative Care Association is a group for people interested in providing palliative care. You don't have to be a specialist, and most of the time, these training programs are made available on those platforms. There are palliative care journals that can be read. But as a nurse, I would say that the Ghana College of Nurses and Midwives currently has a palliative care specialty training program that's ongoing. It's a 3-year program for nurse specialists. But if you want information specifically on breast cancer, palliative care for breast cancer patients, I think the palliative care journals and the trainings that come up from time to time, so something like what we have just done, participating in these would be a good resource to get that information from. I hope I've been able to address it. The second question was hospitals that had palliative care units apart from the Kolebu Teaching Hospital. So I have to say that when it comes to units in a hospital, currently, apart from Kolebu, there's Greater Accra Regional Hospital has one. Tetekwashi Memorial Hospital has another, and actually has an inpatient facility for palliative care services. The only one in the country strictly for palliative and geriatric care. Konfanochi Teaching Hospital also has a palliative care unit. Tamale Teaching Hospital has a palliative care unit, and then Techiman. But there are so many palliative nurse specialists being trained nationwide. The Ghana College of Nurses and Midwives, as I said, have trained so many nurse specialists. So throughout the country, you may have nurse specialists who can provide palliative care. But when you're talking about the units, it's these hospitals that I have mentioned. Yes. Yeah. I think the other question I saw that was for me was how much time should be spent with a breast cancer patient. It's hard to give a specific figure, but like I said, breast cancer patients requiring palliative care depends on the needs of the patient. So how much time you spend actually depends on what the needs of that breast cancer patient are. Averagely, we spend I think the shortest would be about 45 minutes, but we spend about an hour and a half, or even more if you want to do a holistic assessment. And so if, like I said, it depends on the needs. If we are now assessing to know what the needs are and address all of them, it may take a longer time. But if the needs are minimal, then you may take a shorter period. Also, the needs of somebody who is an inpatient may vary, or time spent may vary for somebody who is coming on an OPD basis. So an inpatient, if you have like a hospice facility, may have that benefit of being reviewed numerous times within a day by an ongoing team in countries where they have it. We don't have a hospice in Ghana. Tetekwashi is doing that inpatient. So for them, the reviews can go on and on throughout the day. And so they may have little time spent, maybe 30 minutes and then or 20, and then they move on. But in general, the time is dependent on the needs of the patient. Thank you.
Okay, Dr. Dede, there are a couple of questions there. One of them you did address about mastectomy in the pregnant woman with breast cancer. And then there is another one about support for pregnant women, that is financial support for pregnant women diagnosed with breast cancer. I haven't heard about that. Maybe the National Health Insurance may have to consider that. And then there is also one here which says, is there any situation that can allow breast cancer in pregnancy? You know, say USG aided diagnosis. You know, I do not really get it, but I believe it's a question by Dan.
Yes, I think I understand
Yes.
it. Let me read it and understand and try and answer. Yes. So the mastectomy one has been answered. Yes, mastectomy can be done in pregnancy. We need to remember that really the curative treatment for breast cancer, surgery is very important. So pregnancy, no pregnancy, surgery is important. That's why even when we give chemo and the lumps completely go away, we still have to operate because the surgical portion of the treatment is absolutely essential. Is there any financial support for pregnant women? So breast cancer is actually on the National Health Insurance Scheme. It doesn't cover all the costs, but it helps to cover some of the costs. Some chemotherapy reduces the cost for surgery, some of the tests here and there. So yes, it does help to some extent. And then also for our units, because over the last few years, we've been making quite a bit of noise about breast cancer, especially around October. We tend to get people coming in with all sorts of donations to help our patients. So often we have some funds available for anybody who has breast cancer and is unable to pay for treatment. So we do have quite some funds available to help with that. What's the long-term outcome for children exposed to chemo? So far, the studies haven't shown any detrimental effects. I think from chemo in pregnancy has been going on since about the 1970s, 80s. So actually, a lot of follow-up has gone on. From our end, we haven't followed up our patients for that long. Somehow they tend to get lost to follow up. The one I've seen is the 8-9-year one who is doing very well. But the studies generally, globally, haven't shown any major detrimental effects to children who've been exposed to chemotherapy. And like we said, it's not some chemotherapy agents we know cannot be used. So it's always been limited to what has been found to be safe, and the children have done well with that. Can we refer all cases of breast lumps? I think once you are not sure about anything, you are safer referring rather than saying, let me wait and see what would happen. That waiting period could be the difference between curative and not curative. So I think if we are not certain about anything, there's no harm in referring the patient. Is there any situation that can allow breast-conserving surgery in pregnancy? So for example, ultrasound-aided diagnosis like a T1A, N0, M0 in the first trimester. So basically this question is asking that if you have somebody who is diagnosed very early with very early breast cancer, T1A means that it's actually less than 5 millimeters. And so I guess probably the lump wasn't even palpable, but you make the diagnosis. So the question is, can you do a breast conserving surgery for such a patient? I would think so, and depending on which trimester, how early it is picked up. So let's say this is picked up in the 9th week of pregnancy. You can go ahead and operate, allow the patient 3-4 weeks to heal, 13-14 weeks you start your chemotherapy, do that if chemotherapy is needed, then do that for the next 6 months if it's necessary, by which time you are done with chemotherapy by the time the patient delivers. And then you can go ahead to do radiation, because once you do breast conserving surgery, radiation should be part of that treatment. If, on the other hand, this patient, let's say, does not require chemotherapy, let's say she's strongly hormone positive, she does not require chemotherapy, then all you need is surgery and radiation. If you found this patient in the 9th week of pregnancy and you did surgery, then that means you have to wait for all the 2 trimesters, 6 months without doing anything before you proceed to radiotherapy. That really would not be the best. So in that scenario, you may have to proceed with the mastectomy, and then for such an early disease, she would not need the radiation. Then you can wait after delivery, you can go on to the tamoxifen. So there are no hard and fast rules, but there are the general principles, and we look at individual patients, and then we try and see what best fits the patient's situation. What do you think are the training gaps for healthcare workers to avoid wrong information and management? So I think things like what we are having done today, CPDs, increasing our knowledge on some of these things, because really information, things are changing. Like I said, when I was a student, this is probably not what we have shared today is not what there was. So things would have been managed differently, but things have changed and things continue to change at a very fast pace. So I think one of the important things is not just what goes into your initial training, you graduate and that is it. But as healthcare workers, we all need to be very abreast with what is going on by making sure we join in continuous professional development activities such as this, and also even on our own, reading things on our own, researching on our own. We shouldn't just stick to what we know or what we knew many years ago. That information has changed. So we need to be current and we need to be abreast. I think that helps. Of course, the institutions we work in can help by maybe insisting that every year we should do some activities so that it's not left to us alone to decide whether we want to do it or not. What is the link between hormonal, contraceptive, and breast cancer? So we generally know that breast cancer has a link to hormones. So when we talk about the risk factors for breast cancer, we talk about early menarche, we talk about late menopause, we talk about not having children or having your children late, not breastfeeding. And all these things are related to the hormones, the female hormones. So if we are giving these hormones exogenously, so contraceptives will contain hormones. If we are giving these hormones from outside, then we can imagine that exposing the woman to it can increase the patient's risk. Having said that, again, things have changed a lot over the years. And I think the obstetricians or the gynecologists would confirm that the amount of the dosage, the amount of the hormones in the tablets or the contraceptives these days is not as high as it used to be. And so the risk is actually lower, although it is not zero. So especially for somebody who has a strong family history or some other strong risk, I would rather not advise the patient to be on hormonal treatment. What's the relationship between chemotherapy and hemorrhage during delivery? So we know chemotherapy can suppress your bone marrow. So first of all, it can make you anemic. And if you are starting from a low HB, even just a little blood loss can cause a problem. But more importantly, it can also reduce your platelets. So if your platelet levels are low, then obviously with the hemorrhage that goes on during pregnancy, I mean, somebody with normal platelets will stop bleeding quickly, but somebody who has low platelets may continue to bleed excessively. So usually that's why we give the 3-4 week period after chemotherapy. We make sure that the cell lines have all recovered so that we don't have these complications. Can mammogram confirm if one has breast cancer after a scan detect a lump? All right, so the imaging does not confirm. What the imaging does is that it also gives a suspicion, just like the ultrasound would do. The only thing that can confirm definitely a cancer is the pathologic assessment, which is doing the biopsy. So a mammogram can say Barrett's 5, and you know that honestly, the chance of this lump being malignant is like more than 90–95%, but it is not 100%. It's only the biopsy that can give us that 100%. Is it safe to use a selective estrogen receptor modulator like hormone receptor in hormone receptor positive breast cancer? I'm not sure if you mean in pregnancy. So in pregnancy, no. We just said that hormonal treatment is contraindicated in pregnancy. So you cannot use any hormonal treatment in pregnancy or during breastfeeding. You can only use them after. So during pregnancy, no. After delivery, we ask the patients not to breastfeed, and then we can use the hormonal treatment. Since breast cancer is occurring in younger women, would you recommend that the age in starting mammograms be reduced to 30 years? So I would say the age for screening or looking out for cancers should be early, but mammograms will not be helpful because we know that mammograms in patients who are less than 40 years, generally, some people drop it to 35, but generally we use 40 as the cutoff. Less than that age, the breasts are so dense, and so the mammogram does not show much. So you can do the mammogram, but you will not pick anything. Actually, some patients who are even more than 40 tend to still have dense breasts, and the mammograms are not so useful. So using mammograms from 30 years will not be useful. But then we can do, here we still recommend the self-breast examination because we know that we are picking cancers so late. We are picking 5, 6, 10 centimeter lumps. If we're even regularly doing self-examination, we can cut that down to maybe a 2 centimeter, a 3 centimeter lump, which is clearly an earlier stage diagnosis than picking up the much more advanced disease. So not mammograms, but other modalities that may help us to pick cancers early. We could do ultrasounds, but studies haven't really shown that doing ultrasounds early, maybe it's something we should look at, would be so useful. We know that even mammograms, there have been all sorts of positives and negatives to it. MRIs are also good, but not for the general population because the risk may not be so high. For in people who are at high risk, young people, those ones can have MRIs done regularly. How about inflammatory type of breast cancer, which does not present with a lump? Can the surgeon throw more light on that? How the patient presents? So the patient presents with a general swelling of the breast. The whole breast is swollen, and usually it's warm to touch, it's painful, and like you rightly said, you do not pick any lump. We tend to see the pod orange or the orange peel appearance of the skin. So that is how the inflammatory breast cancer usually presents. And so even in making a biopsy, trying to take a biopsy, we tend to go for an incision biopsy rather than a core needle biopsy because we can't get a definite lump and it's all the whole area that is generally involved. And that is usually confirmed from, at times you think it looks like that, but the histology doesn't confirm it. So usually the histology will confirm that for us. Treatment starts in 3rd trimester and it takes 6 months. No, it starts in 2nd trimester. Chemotherapy starts in 2nd trimester. So right from 13, 14 weeks, you can start. When will this treatment finish for mother to build up HB for the surgery to be done? Yes, so treatment starts in second trimester. But if you are asking because the diagnosis of the CA was done in the 3rd trimester, so somebody's diagnosis may be made when they are 26 weeks. That is when they've come. You couldn't have started it earlier. You didn't have the patient then. So then with that one, you cannot finish all the chemotherapy. So you calculate, if you do 26 weeks, you can do 26, 27, 20, you can do 26, 29, 32, you'll probably have to stop. So you do 3 and stop. So this one, you have to induce delivery at 36. You can't sit down waiting for the woman to go into natural labor. At 36, you induce delivery, you let them recover another about 2 weeks, and then you continue the chemotherapy. So depending on when you start, you may not be able to finish, but you may have to break to have delivery, and then you can continue. I think I've answered this one already. Is it safe to use the tamoxifen in hormone receptor positive? I've said you cannot give hormonal treatment during pregnancy. Okay, 2nd trimester, yes. So I think I've answered the question. Are cancer treatments affordable? That's an interesting question. It is expensive. So right from doing your mammograms are usually about, I think now it's about 400. Biopsy, you buy the kits for, I think 300 cedis. And then you do the histology for another, maybe averagely 500 cedis. And then you do your CT scans for metastatic workup, which may be approaching 2,000 cedis. You start chemotherapy, you do surgery. Surgery may cost anything between maybe about 4,000 plus or minus. Chemotherapy, depending on the agents you are using, it may be covered by insurance, so you don't need to pay anything. But some can go as high as 1,000, 2,000 or more every 3 weeks. Herceptin, that is actually like 5,000 cedis every 3 weeks. But thankfully, that is on the health insurance. So most people don't have to pay for that. Health insurance covers it. Radiotherapy, it's about $1,000 plus or minus. So I don't know what you mean by affordable, depending on whose pocket you are looking at. But generally, it is expensive. And that's why I said that on our unit, for instance, we have a lot of help. We have a lot of groups and individuals who come to help, because with these amounts I've mentioned, you can imagine that a lot of Ghanaians may not be able to afford payments or treatment for these conditions. We have people who sell sachet water on the road, people who, all sorts of petty traders, artisans, a whole wide range of people. So some, yes, are able to afford. Some companies will take care of them. Others, we have to help. And especially if they have the insurance, that also helps a bit. During the presentation, I realized there's no committee who goes after patients who default treatment. Is there any measure put in place to follow up clients if they default or start missing appointments? Actually, there is. So we have breast care nurses who take the details of every patient we see, and they actually follow up the patients. At times they call them, and I mean, we've had all sorts of stories. The patients give excuses, the patients will not pick up, the patients tell them they are not coming. So it's not for want of trying. We actually do follow them up, but unfortunately, our efforts do not always yield the results we want them to yield. When somebody is booked for surgery, they don't show up. We always call them. And then they may either say, oh, I'll come next week or something, or at times they give you all sorts of excuses, or they may not even come at all. The breast care nurses have gone to the extent of following patients to their homes. They actually follow up, and they have very interesting stories to tell. So rest assured that we are following them up, but we are not always successful. How much is our Ghanaian culture influencing the late presentation of breast cancer in pregnancy? Well, I mean, I think generally, even non-pregnant women are coming late. So that's even the starting point. And then, like I said, in pregnancy, it's a little more complex or a lot more complex. The same breast that you are going to use to breastfeed. Now we are saying that you have breast cancer, it has to be taken off. It's a very difficult decision. Even for those who are not pregnant, they don't want us to do that. So when the pregnancy adds to it, then you can imagine they will not even come near us for us to tell them that. So clearly, I mean, the culture has a role to play, but we are hoping that as we talk more and more about breast cancer, and more survivors share their stories and people know that it's not a death sentence, you can have treatment and all that, hopefully we would make some progress. Thank you. And now a palliative care question, so I can take a break. Abena, please, can you answer that?
All right. First, I think about how do you continue to give palliative care to a family of the dead? Yes. So thank you. That is mainly through bereavement support. So it can be psychologically traumatizing. So in fact, the care starts even before the patient dies. But then after the patient is dead, you need to screen for any abnormal or prolonged grief. Even the immediate bereavement process is a difficult one, and they need all the support that they can have. There's sometimes informational needs that have to be met. There's anxiety. Will somebody get this? Have this illness or disease? Can it be transmitted? What are my chances? All these things have to be discussed with the patient. With the family. Sometimes allowing people in the family to be part of volunteer groups. In most countries, you have volunteer groups as part of the palliative care unit. And so people channel their energy, their resources into helping other people. They may have gone through experiences that they didn't like, and it becomes an opportunity and avenue for them to help other people so that they don't go through exactly what they went through. The support to the family can also be through preventive measures and screening. And for instance, somebody has hepatocellular carcinoma, you caught late, but hey, you can screen people if it was due to Hep B and put in preventive measures to prevent the family members from also getting it. So it spans. It's a whole psychological support to informational needs, involving them in their care, and also screening and preventing these diseases from recurring. Okay, I think Dr. Dede, the rest is still yours.
Yeah, may I come in? Dr. Sapo, from where you sit, are you very confident that with each passing day, there is a better appreciation of the role of palliative care, in our scheme of things? Because for most health professionals, they still think that palliative care is synonymous with hospice care. And what do we have to do really to change the narrative?
Yes, thank you. I think that there has been an improvement, but there is still a long way to go. I think that we need to intensify education on palliative care, give feedback. We probably also have to be writing more and letting people understand what is going on. The truth is that probably people currently in position to lead referrals may still have the misconception that it has to be end of life care only. But even in the medical school curriculum, it's a whole lecture is now given in palliative care. And so I think that we need to rather intensify palliative care awareness, give opportunities for people to enter into palliative care programs, and also even nationally to come up with policies to help with palliative care. I think right now it's an area that still needs a lot of improvement, even in Ghana Health Service. So it's something that we need to give more attention to and intensify our education. It's improved, at least from the time I started till now, it's improved, but there's still a long way to go. There's still a long way to go.
In fact, I believe that one cliche that we should really highlight is the fact that, we have people or patients afflicted, but everybody around them is affected, So the earlier everybody got involved, the better,
Yes.
because if you have a patient that, is supposed to, get early intervention so that quality of life is not seriously impaired, and that opportunity is not taken, then of course, when bigger challenges set in, everybody around is going to get affected, even including the caregivers, because
Yes.
the medical caregivers, because let's face it, there are certain patients when they appear, in your consulting room, you are saddened because an opportunity has been missed to make an impact, and they'll keep coming back. So it is for us to really let everybody know that it's in our collective interest to really get these multidisciplinary approach to healthcare, really on the front burner. Thank you very much. I have a question for Dr. Dede. Have we had any prevalence studies on the breast cancer in pregnancy, at least hospital-based?
Not that I know of. So at the time we wrote the paper 5 years ago, we just looked at some of the cases we had done, and we used those ones like a case series. But I'm not sure if anybody has actually documented all of them. I don't think so. I can check with the oncologists, but I don't know about that. Okay, so I think I can continue to answer the questions. I think the next two are about the same. Can a woman with breast cancer breastfeed her baby safely after treatment? And then can a woman who has completed chemo breastfeed, and for how long? So yes, during chemo, no, but after chemo, 3 to 4 weeks after chemo, it's safe to breastfeed, and you can breastfeed for as long as you can once you are not on either chemo or hormonal treatment or getting radiotherapy. So those are the ones that are contraindicated. So if it's after the chemo, 3 to 4 weeks, it's okay to breastfeed. How best can the laboratory assist in championing this goal and aiding early diagnosis? I would assume we are talking about early diagnosis of breast cancer. So clearly we know that beyond the self-examination, the other things the laboratory can do are the imaging studies. So for the more than 40s, not for the pregnant women, but for the non-pregnant women, we recommend the yearly annual mammograms because that can be very useful in picking up early breast cancer. And then ultrasounds can also be helpful. So especially when there's a complaint, we shouldn't just examine the patient and just say, oh, there's nothing, it's okay. At times the patient insists and we finally end up making a diagnosis of a breast cancer. So for me, anytime there's a complaint, a breast complaint, even if I feel like the history is not really pointing towards anything, the examination doesn't show anything, I will not end that examination. At the very least, I would ask for a mammogram and or an ultrasound, depending on the age. So imaging when it comes to breast disease is very important. And with any breast complaint, we should actually go ahead and do some minimal imaging to rule out anything sinister. 40 years gravida 1 para-0 first trimester pregnancy with breast cancer that requires new adjuvant chemo. Do we have to wait for second trimester before starting treatment? What option do we have? Yes, so in first trimester, we cannot give chemotherapy. If it's a fairly early, sorry, you said it's requiring new adjuvant, so it cannot be fairly early. That means that it's probably not operable, because if it is operable, then you want to start by doing surgery so that you can buy time, get to the second trimester to start the chemo. But if it is not operable, then you don't have a choice but to wait. The other option is to offer termination of pregnancy so that treatment can proceed. But gravida 1 para-0 40, maybe a precious baby, and the patient may not be interested in that option. But from the medical point of view, that is also an option that can be discussed with the patient. Are there any concerns for cardiomyopathy with chemotherapy in pregnancy? So generally, we know that some of the chemotherapy medications actually predispose to cardiomyopathy. So specifically adriamycin, taxanes can do that to a small extent, and also Herceptin. But then Herceptin and taxanes are contraindicated in pregnancy. So it's the adriamycin. So if this pregnant woman has comorbidities that are already putting her at risk of cardiomyopathy or cardiac comorbidities, then I would definitely start, before we start the treatment, do an echocardiogram. So usually we are interested in the ejection fraction. And if it's less than 50, then we do not give adriamycin. So yes, there is a concern for cardiomyopathy with the administration of adriamycin, but we take the necessary precautions by doing the echo, make sure the patient's heart is functioning well before we go ahead. If there's a patient who already has cardiac disease, then we cannot add adriamycin to it. Are there any special consideration indications to which the termination of pregnancy is the only option for pregnant women with breast cancer? So I think I've mentioned one where you could consider termination. Very early pregnancy, advanced breast cancer, requiring chemo, and you cannot do chemo. So let's say a patient has come 6 weeks pregnant. You cannot operate. The only other option is chemo. You cannot give chemo till 14 weeks. So are you going to wait for 8 weeks not doing anything? That may not be a very wise decision. So termination can be considered, but it's in consultation with the patient. At times too, you start the treatment, let's say you start the chemo 14 weeks, you give 3 cycles, 14, 17, 21 weeks, the patient did not respond. Instead of getting smaller, the lump is getting bigger. The other, and it's not operable, the other second line, third line options cannot be given in pregnancy. So that is another scenario where you may have to discuss termination of pregnancy so that the mother can get the needed treatment without the cancer getting out of control. If a patient comes with a bloody nipple discharge at 8 weeks gestation, how should the workup and management at a district hospital be, or should we just refer? So at least you can start by doing an ultrasound. Depends on what the history is. It could be just a dilatation of the ducts, a ductectasia. But usually once we hear bloody, we tend to be a little concerned, because then the chance of it being a malignancy is a bit on the high side. So we'll do the ultrasound. It may tell us that there's a papilloma or there's an intraductal mass. If it's possible to biopsy that mass, if it's big enough for the radiologist to biopsy it for us under ultrasound guidance, because normally it's not palpable, then we can do that. And if we get a biopsy that tells us that definitely this is not malignant, we could I mean, we can even still go ahead and operate because surgery is safe during pregnancy. So we can go ahead and operate so that we get the actual mass, send it for histology, and be sure that we are not dealing with anything worrisome. If the ultrasound doesn't show any intraductal mass, we can do a cytology of the discharge. And if there are no malignant cells, then probably we can observe it and see. Occasionally, it may be some form of trauma. They just get a passing bloody discharge and then it subsides. But if it's persistent, then often you want to get to the point of taking out that duct, even if your scan and cytology haven't shown you anything. Once the discharge is bloody and persistent, you actually want to take it out and send it for histology. A patient just died from breast cancer. Her mother died of same. She left 2 daughters. What are the chances of these 2 daughters also getting infected? And most importantly, how can we prevent the daughters from getting breast cancer? So just by virtue of the fact that mother and daughter have had it, makes it sound like it's genetic. But more information would be helpful. So for instance, at what age did the mother get it? At what age did the daughter get it? The mother got it at 85. Let's say the daughter got it at 60. It could be that it's actually not genetic. But if the mother had it at 45, daughter had it at 32, the earlier the breast cancer is diagnosed, the more likely it is to be genetic. And if there are other family members who have it, if any of them have had a bilateral breast CA, all these increase the chances of it being genetically predisposed to. So what we can do is, depending on the ages of the daughters, I don't know if either the mother or the daughter had the genetic test done. Here usually we'll do the BRCA test 1 and 2, but there are a whole other host of panel of genetic mutations that can be tested for. So just doing the BRCA 1 and 2, that doesn't give you all the answers because it could be negative, but there could be other genes that are positive. So if we could do a more extensive genetic panel testing, then that would be more helpful. And if any of those come up as positive, then you know that the chance of the daughters or the granddaughters also getting it is quite high. Then you could talk to them about prophylactic measures. So the most effective would actually be prophylactic bilateral, or they say we shouldn't say prophylactic anymore, risk-reducing bilateral mastectomy. We say risk-reducing because the fact that you've taken off the breast does not reduce the chance of a breast cancer to 0. So there's still the possibility, even after a bilateral mastectomy, that a breast cancer can occur, but the chance is reduced by like 95%. So definitely it is useful. So that is the most important or the most effective measure we can use. But that's a drastic measure. Not everybody may want to do that. So if you're not interested in that, the other thing is at least 10 years earlier than the youngest age at which either mother or grandmother had it, they should be doing a very intensive screening, if I can call it that way. So if they are less than 40, then mammograms may not be useful. Then we may have to look at MRIs. If they are more than 40, we can do mammograms, but still intersperse it with MRIs. And then again, just the breast self-examination, it's always helpful because you can have some cancers developing in between your screening tests. So, I mean, these are the things that I would mention in terms of the daughters and what they can do. How do you differentiate mastitis from breast cancer of early stage? So it can be a bit difficult. Today, for instance, I saw a diabetic with painful, swollen breasts, was even fluctuant at a point. So my first differential was that she's 70-something. She's diabetic. My first differential was that this is an abscess. But then she had done a scan, which said that she had suspicious lymph nodes. So is it that it's an abscess which is superimposed on a malignancy? That can also happen. So usually what we do when we are not so sure is to first treat the infection. So give them antibiotics for a short while, in a week or 2, review them. And if it's not subsiding, if the symptoms are not getting better, then definitely you need, if there's any residual lump, you need to go ahead and biopsy. If there's an abscess, then usually we drain. And at the drainage procedure, we'll take a biopsy of the cavity so that if there's any underlying malignancy, we pick it up. But yes, it can be a difficult diagnosis to make. At times you do the biopsy and it tells you chronic breast abscess. So we keep an eye on it for a while. But if chronic breast abscess ends up with a residual mass, and that chronic breast abscess, the residual mass is never going away, then we should plan to operate and take out that lump. And quite a few times it ends up being a malignancy. And they still take their usual routine medications alongside the chemotherapy, including SP. Please, I don't know what SP is. Malaria prophylaxis.
Yeah.
Okay, yes.
Yes.
Yes, I don't think there's any contraindication to doing that. But that's why the obstetricians are always involved in the multidisciplinary team. What we don't want them to be taking is the folic acid, because that can increase the rate of growth of the cancer. So usually we don't like them taking the folic acid, but we always have a multidisciplinary team taking care of them so that we can discuss whatever the thorny issues are and come to a conclusion together on what is best for the patient. Young people with breast cancer have amenorrhea. Why? If they are on treatment, then we know that chemotherapy can induce amenorrhea. So if it's those who are on treatment, then that could explain the amenorrhea. Otherwise, if it's very advanced disease and the patient is under so much stress, we know that stress alone at times can cause amenorrhea. But I think it's more to do with the chemotherapy. When the patient is on chemotherapy, they tend to get chemotherapy-induced amenorrhea. What is the time spacing between the chemo starting from the second trimester? How many weeks apart for each session? So for breast cancer chemo, usually we do it every 3 weeks. The regime that we use is usually every 3 weeks. So starting from 14 weeks, every 3 weeks till complete. Or depending on when you started, if you started late, then we may not be able to complete it because you get close to when you have to deliver. We stop 32 to 34 weeks, allow you 3-4 weeks to recover, and then delivery can happen.
Dr. Dede?
Yes, please.
I think I have to come to your aid because, you know, people are so attentive. You've tickled their imagination, and if we don't come to your aid, we'll be here till tomorrow morning. I think you all agree with me that we've had a very, very fruitful session this evening. I have learned a lot. I mean, you wouldn't believe it, but we had over 1,000, people participate in this all-important session. I believe that we will all live here, better informed. We wouldn't have to keep whatever information or knowledge we have acquired, we should share. It should inform our practice. It's been made quite clear to us that palliative care is not hospice care. Palliative care has lots of benefits, and we should always remember that it's a kind of supportive care. Communication with our patients is important. Sometimes we say, oh, lots to follow up. Some of it may be due to the way we communicate to these patients. Because, look, there are people out there proffering all manner of solutions, spiritual, physical, and what have you. So if we don't communicate well, we don't educate our patients very well, they will all fall prey to those out there ready to make some money off these unfortunate situations. There's always a need for us as a nation, to build capacity in this area. It's also quite clear to us that palliative care should be provided by all of us. It is not just the palliative care physicians. Much as breast cancer is the commonest cancer in women, it's also been established that it is the most common malignancy in pregnancy. And therefore, there's a need for us to be vigilant We should never take any breast complaint in a pregnant woman lightly. We have to, always probe further to find out what is happening. For us to be told this evening that there are people in their 20s battling breast cancer during pregnancy, should raise alarm bells. So as practitioners, we have been positioned to pick up these conditions because there is hope. A lot of what we heard this evening can be termed as message of hope. And once we imbibe that in whatever we do, our patients will be the beneficiaries of that. Please also remember that that old terminology of prophylactic mastectomy is now being revised to risk-reducing mastectomy for reasons that have been explained to us. I would say at this juncture that if this presentation had taken place in an auditorium, the two of you would have earned a standing ovation. I don't know how much to really express my gratitude and to also emphasize that we've all learned a lot. I would also thank organizers for this wonderful arrangement. I would thank the participants for being patient, being very active. It is really during the Q&A that, a lot of issues that were not clear are elicited and clarified. So we've all been really educated this evening. So once again, I want to say a big thank you to Dr. Dede and Dr. Sapon for this wonderful presentation. And the final word will go to the organizers. So Dr. Amu, are you there?
Yes, Dr. Anote,
Yeah.
I'm around.
So I'm handing over to you at this juncture. Thank you very much.
Okay, thank you very much, Dr. Anote. And just also want to say a big thank you to all of you were able to join the call. And for us as Global Outreach Consortium and then Bisayan projects, we are grateful to all the attendees for your presence and the engagement that we have had. And I also want to use this opportunity to just mention that next week we'll be having another CPD, which is the second event of this series that looks at the breast cancer in special situations. And we look forward to welcoming you once again, and as we all continue to explore and deepen our understanding of this important subject. So until then, thank you and stay well and goodbye.